Symposium this morning, and Dr. Levy was not able to be here, so he wanted me to introduce us all. We'll each be giving quick talks on different areas of research and innovation. And we wanted to thank for the participation for all the industry in helping us support the symposium and all the different forms of innovation that we have in our department. I'm gonna get started. We're gonna do a little quick switch between Ashish and I, and I'll go ahead and go first. So I'm gonna be talking a little bit today about the role of cadaveric dissection training in neurosurgery residency. I feel like Dr. Hiros might have a lot to say about this, so please feel free to speak up. So everybody knows me. I think I'm Carolina Benjamin, and I am the director of the skull-based lab here. So I'll share some of what we've been doing there as well. So I think if most of us should know, the man in this photo, Professor Yashar Gil. He's known for a lot of things. He was Turkish, but he practiced in Switzerland, and he really was sort of the quintessential professor. He was known to be a technician, an anatomist, and an innovator. Really was an inspiration to many students, neurosurgeons throughout the entire world, really. And this is, somebody who we in neurosurgery really know as a master. And we'll go into a little bit more detail about what we mean in terms of mastery of neurosurgery. One thing that's interesting to note here is if you look at some of these pictures in the OR, there's really only him and the scrub nurse, who happened to be his wife. And it's interesting because somebody of that level often, or that caliber, you often have like an entire group of people. It really becomes an operating theater. And it's interesting here to see the level of concentration, and everybody's sort of set aside, and the area of focus and is really just two people. This is an event. This is something that he's doing, and it's very important to have full focus on the patient. And I think that's an interesting thing about the pictures that we have here. So another interesting thing here, he was named as Neurosurgery's Man of the Century in 1999 in an article in JNS. 20 years down the line, Roton got that same title, and so on. And you can see here in this photo, it's Professor Yashar Gil actually positioning a patient, pinning the patient. And I think that's an interesting also picture to note, because a lot of times, the residents overlook positioning, and that's really a critical portion of the case. You'll notice that many of us, I know Dr. Marcos, myself, and this is the way I was trained. You essentially that's one of the most important parts of the case. And if the positioning is not done optimally, certainly the entire case can be less than suboptimal, essentially. But there are very small nuances in positioning that I think take perhaps the entire time of your residency to really start to note. I think that's an entire lecture in and of itself, sort of the nuances of positioning and how to maximize your exposure and maximize your surgery. So that's an interesting thing that this picture here, Professor Yashar Gil, is sort of demonstrating that. So this is an interesting. There it is. That I didn't know. A ritual, it's a real thing, and it's part of the checklist, right? Nowadays we have all sorts of checklists, and certainly these are small things that become part of your checklist that really become important, and we don't. Sometimes you think, oh, you can overlook this, overlook that. If you think of an airline company, if you think of somebody flying a plane, nothing's really ever overlooked. So this is sort of just shows the emphasis of that. So anyway, so this is one of the Cincinnati Microsurgery Symposium. So the top picture, I think the 1971 got cut out, but the top picture is in 1971. This was Cincinnati was sort of the seat of American microneurosurgical education at the time, and they would have these symposium. So a lot of the symposiums we're having today and that we just had at the AANS, this began a long time ago. This focus on using the microscope to operate, and how this would become the future of neurosurgery. And we may not know all these, these folks in this photo, but certainly a lot of very famous neurosurgeons are there. And people used to gather and have these symposium. This dates back to a long time ago in neurosurgery, and it became a meeting of the minds. And I think that's an important thing to remember. So how can we really generate this next generation of Yasher right? So that's the true question: is how are we going to generate? Do we even need to have that next person, that next sort of genius? Essentially, cases, we have increasing case complexity, decreasing numbers. And then we have equipoise with sort of minimally invasive neurosurgery. Right now, we have the advent of neuroendovascular, we have Gamma Knife, we have the endonasal approaches. So, do we really, since we have a small number of these really complex cases, do we really need a high number of surgeons to do this? And this question of equipoise is an interesting thing, right? So when we started out gathering data on these minimally invasive approaches, essentially you would have a technique and you would have some sort of new gadget or new technology to do it. And if the surgeries or the results weren't going well, people would sort of come back to you and say, well, two things. Number one, the material we have is not perfect, or it could be improved. And number two, there's not that many of us doing this, so you can't. There's no equipoise. You can't really say that endovascular is not as good as open surgery because number one, we're not doing it very often, so cut us a break. And number two, the material isn't perfect. So are we reaching a point where that is now the case for open surgery, right? Because there are going to be a lot of people who are not trained in open aneurysms and open complex surgery. So are you going to reach a point where you say the opposite is true, where there's no equipoise because there's not enough people with enough experience for open surgeries? And that's an interesting concept, and I'm not really sure that we ever thought we would get there. But are we going to get to that point where, there's not enough surgeons that are really trained in these open procedures? And so if we don't have these highly skilled people, do we really not have equipoise? So what are the characteristics of somebody that is as talented as Yasher Gill? And what about our current educational models? Do we even have a current educational model that's sufficient for people to get there? Is it enough time? Is 7 years enough time? Is there a fellowship necessary? And what are the selection models, if you could say we have selection models at all? Or is it that anybody who's interested in becoming the next, cerebrovascular or skull base master can just do so by virtue of interest? That's an interesting thing, who should be selected, or who should be allowed to go into these fellowships and into these training programs. So this is the requirement. This is the neurosurgical RRC, the resident review committee. They set out required minimum numbers, right? So they essentially say what they define is how can we say that a resident is competent enough to perform a certain procedure? And you can see there's a list of these things, I think, here for a craniotomy for aneurysm, or no, craniotomy for a vascular lesion is 40. Is that enough of a number to call somebody competent in that area? And it doesn't even say aneurysm, so just a vascular lesion. Maybe this person did 39 cavernomas and 1 aneurysm, right? So you're thinking about how can you say that that's enough? So this is where, I think really CAST accredited fellowships become really, and non-CAST accredited fellowships as well, but fellowships become really critical because that's when you're going to really master your technique. There's something called an RRC index, which is essentially, they said, the RRC got together and they said, a good RRC index means that you take the number of cases that your program does and you divide it by the complement. So say you do 100 aneurysms and you have two residents a year, your RRC index is 50, right? So that's considered to be a good RRC index for aneurysms, right? 100 a year is pretty decent. They actually looked at fellowship, the places where they don't have fellowships, CAST accredited fellowships, and actually that RRC index, the median was actually 7. And then, the median was 18 and the minimum was 7. So there was a program where the RRC index was 7, meaning that they only did 14 aneurysms a year. Yet that program coiled 180 aneurysms that year. So, obviously the pendulum in that program swung significantly. But so what does that mean for resident training and for getting the experience of anatomic sort of knowledge? And then interestingly, for the fellowship, for the programs that did have CAST accredited fellowships in open vascular, which is where you think some of these people who are really interested in becoming skull-based masters or cerebrovascular masters are going to be in one of those programs, at least for their fellowship. The median index was only 38. So the total number was not as high as you would expect. The maximum was sort of around 72. So yeah, that's 140 aneurysms a year. That's very good, but that's not every program. That's a small number. So it's an interesting thing looking at what that means. So how do you get there? So what's happening and how do you get there? You essentially have to, this is a response curve. So essentially the more dose you put in, the more time you put in, the better the response you're going to have. That goes for neurosurgery, that goes for, sports, skiing, playing the piano, whatever you want to say. So what this means is, how are we going to get good if we're not having that many cases? You have to shift the curve. Now, shifting the curve or making the curve steeper is actually kind of a misnomer, because you're not, if you think about it, something that's very complex, you're not getting better at it by learning it faster, but it's going to take you longer to do. But what you have to do is you essentially have to shift the curve in order for you to get better at it. But that's essentially what's happening here. You essentially have to shift this learning curve in order for people to be able to get to the same level of mastery. And the real question becomes, is that possible? As we all know, and everybody would probably, this is sort of like, there's a lot of data to talk about volume and whether volume correlates with outcome, right? And I think everybody probably agrees that a hospital that does a lot of something is going to get very good at it, and therefore they're going to have better results, right? But an interesting thing, there's an equal amount of literature supporting that this volume phenomenon doesn't really translate to the individual level. So there are some people who don't do things at a high volume, and yet they're very good. They have very good results. So why would that be? So I think the difference there is aptitude, right? So there's something that perhaps some surgeons can bring to the table that is not necessarily one-to-one related to that learning curve. And therefore, for those people, you really don't need that shifting of that learning curve, So that's an interesting concept. So that brings us to levels of expertise. So I think it's interesting, you want to think about, there are different levels of expertise. We all go through this, right? Nobody comes in from, nobody matches into neurosurgery residency becoming a master surgeon. That just doesn't happen. There's a natural progression, right? So the novice, which is you must be taught when you're at the level of a novice, and you use context-free features and rules. Then you reach the level of competence, which is safe performance of a procedure within a reasonable amount of time. And that's sort of what residency training looks for. That's what the RRC is talking about, right? When they look for competencies. You can become proficient, which means you're going to have expert performance in terms of task, efficiency, and outcomes. So it looks at timing as well as outcome. And then you can become an expert, someone by virtue of their level of knowledge and skills recognized as an authority in something. As you go up in this starts to become a little bit less objective. And then finally, you get to the level of a master, which is somebody who produces a masterpiece. And again, it becomes a little bit more subjective, right? But the ABNS and the RRC really say that you just have to achieve competency. That's not Yasher-Gill territory, right? So that's not that top of that learning curve that we talked about. So then how do you get there? So how do you, who gets to the mastery? Well, it requires a lot of psychomotor skills, and then coordinated mental and physical abilities. And I think, look, some of these things are interesting to look at, obviously reaction time, precision of your movement, which often sort of translate to efficiency of movement. Aiming, if you look at, PGY1 with a bipolar and a PGY7 with a bipolar, their aim at what they should be looking at and operating on is very different. You want to be able to do, the sort of the steps of surgery without necessarily thinking about what am I going to do next as a natural progression. Anticipation, decision speed, your ability to make that decision on a quicker focus, consistency, can you reproduce your movements in the way that you want them to be reproduced, and sort of strategizing. Can you have a strategy in mind, and then are you able to sort of be malleable and change that strategy as you go along based off of how the surgery is going and what you need to do. So this is not a simple thing to do. And then how do you get really to the top? Well, elite performance, right? That's how you become a master. And look at some of the things here. Deliberate practice, sure. Some of the psychomotor skill set that I talked about, confidence is important. Attentional control, coping. Coping is an important factor of becoming a master. And I put here, Dr. Morcos's excellent article on neurosurgical complications, because this is not something that's taught necessarily. A lot of these skills that are here, how you get to this mastery level, are not necessarily skills that are taught. And then, the metacognitive experience, which I think, Turkey, you gave a great talk about that book, Flow. And then mentorship early on and through all different stages of your career is also very critical. So these are all important things. And you can see here that, again, this is another learning curve, and the importance of mentorship in helping shift that learning curve. You only really get there through mentorship. So you got to put in the time. That's important, right? And I think everybody who has read Malcolm Gladwell knows his 10,000 hour rule. Says that if you look at any kind of cognitively complex field, from playing chess to being a neurosurgeon, we see this incredibly consistent pattern that you cannot be good at that unless you practice for 10,000 hours, which is roughly 10 years if you think about 4 hours a day. So putting in the time, there's nothing that replaces it, and there's no really avoiding it. But that doesn't, just because you put in the time doesn't mean you're going to reach that master level, right? So who reaches that master level, and who's the ideal candidate? So should we say that somebody who comes in and is a hard worker, they reach their core competencies? This is a resident who's a team player, academically productive, and interested in, say, cerebrovascular skull base. So should that person automatically be allowed to sort of partake in this? And should that person be the chosen person to sort of become the next Yashragil or the next master? Well, maybe, but what about aptitude and flair? And flair is something that, you can sort of, these are things that you, again, are not really spoken, but you can pick up on in the OR pretty quickly. Somebody who's going to be a leader in the field, who's going to be innovative, and who's sort of going to move the needle ahead. So I think there's probably a combination of both, but how do you get there within the constraints of today's training? And another unique problems that we face in skull base and cerebrovascular is that a lot of these most difficult cases are really rare. So they're few and far in between. Even early on in your career, you're going to be doing a few of these, you might do one case and then not do another one for a few months or even a year. And that's a problem, right? Pathology can be variable in terms of size, location, texture, and vascularity. The approaches are multiple. You have to be well versed in multiple approaches, be it open, endoscopic. If you're doing vascular, certainly be knowledgeable about the endovascular options. And then complications can be sudden and often unpredictable, and that's very difficult to handle. And the cases can be very long. In speaking and sort of hearing some of the masters talk about what their toughest learning curves in terms of skull base, really, vestibular schwannoma surgeries, and I think Dr. Morcos talks about this a lot. Giant pituitary tumors, and which choice of approach are you gonna, which one you're gonna choose, or both if necessary. And again, that plays back into being well versed both in open skull base techniques as well as endovascular techniques, and then skull base meningiomas, which oftentimes involve not only skull base, those surgeries not only involve skull base skills, but also being a master cerebrovascular surgeon. So that can be interesting and tough too. And that goes to the again, Dr. Morcos's concept of skull base and cerebrovascular being the inseparable twins. You really have to be able to handle both in order to be able to be an excel in skull-based surgery. And then, and I think Dr. Morcos is going to speak about this in his talk, in order for you to be able to be a master vascular surgeon, you have to often know complex skull-based approaches. So, they really are inseparable. So how do you get there? The lab, right? With the constraints of what we have in terms of residency training, in terms of getting to the 10,000 hours, the lab is really one of the ways to do this. And I think, the legacy that Al wrote and has left us in terms of anatomic dissections is wonderful, from the sense that, it's done, it's there, we can all see it, we can all study it, but it's not the same as experiencing it. And you can see here, this is a photo of him with, in a skull-based lab with the residents. This is, I don't think I have a pointer, but these are some of the fellows that he has from all over the world. There are people, and you can see Dr. Morcos is in that photo, and this is really just quite an incredible thing that he has left us with. Back when I was a resident, everybody used to carry around that red Roten book with them everywhere. It's very different nowadays. Nobody has the physical book. I don't think. I don't know if they sell it anymore, is what the residents tell me. But if you don't have it as of the book, you should definitely have it as a PDF, and you should know that we have the Roten collection online. This is available and free, and everybody has access to it. Incredible pictures. There's 3D anatomy. You can do this in 3D. You can do this in regular. And you really should be going through some of that. And that's why I sort of started that Roten session with you guys every few months or so, because I think this focus on the way to become a really great surgeon is be a great anatomist first. So, there are a lot of studies that are done now showing the importance of laboratory training in neurosurgery residency. So out of 100 programs, 65 responded, so pretty good, 65 response rate. And out of those programs that responded, 93% of them currently incorporate cadaveric or anatomic or animal dissection in their training program. The sessions per year varied. Most of them had about 4 to 6, which is probably where we're at. And then a combination of cranial approaches, endoscopy, microvascular anastomosis, as well as spine and peripheral nerve. And here in our lab, we've done just a little bit of everything. And now I know everybody's focus is sort of on AI and using, machine learning to simulation techniques. Is that as good as cadaveric training at, and so they question that as well. So do you believe that the potential impact on resident education is greater from simulators in the current technological state or laboratory dissection? And everybody sort of tended to agree that either it was laboratory dissection was better, or it could be equal, but certainly simulation does not replace the cadaveric learning. And I think that's important to focus on. I think some of these tools, the upsurge on, they're good, they're very good, but they don't replace, the actual cadaver head and the dissections. So how do you do this? And there's different approaches. And I know, in the past, we've sort of done skull-based lab and we'll choose a complex approach. But then, I realized the more junior people, they haven't even gone through basic skill sets of learning how to suture, of learning how to make a burr hole. So, this study was interesting in that it showed that actually a stepwise training program was the best way to go about it. And this was a single institution in Portland, Oregon, but essentially they had core competencies, and each level, they sort of divided it up by levels, which is how we've done it this year. The first few hours you have the juniors come, and then later on you have other residents come, so that everybody can learn based off of their level. So I think there's enough data to show now that, incorporating these curricula actually helps in terms of getting people to where they need to be so that they're prepared for their task in the OR. PGY1 doesn't need to go to the OR and be able to do a Kawase approach. They need to be able to do, basic suturing of the dura, of making a burr hole, of turning a craniotomy. So now we have some data to show that, and I think that's very good. And overall, the satisfaction in terms of how people feel about these courses, it's overall very positive. I think it's hard to set aside the time. It's hard to get access, in terms of faculty being there, because I think that's what ultimately is, these things have to be supervised or at least guided. You're not going to do as well if you can be, dissecting something entirely wrong. And if you don't know that you're doing it wrong, that's not going to be helpful. So part of, at least in this study, part of the issue was having faculty and senior residents available to sort of help guide the more junior residents. But overall, once people can get there, even if it's for an hour or two, it's actually proven to be very beneficial. So then some people will say, well, the downside is it's not really realistic. This doesn't translate. And people have been looking at this for a very long time. This is from 2002. This is again Yashar Gill and Al Mefti, and they're trying to make simulators that make it the whole laboratory experience more realistic. And so this started back in the day, and actually this is that Gabby Zada at USC has done a phenomenal job in sort of creating perfusion-based cadaveric simulation models. And I don't know, maybe Tyler, you've tried his perfusion models. Certainly, if any of you guys go to the skull-based meetings and they have an option for you to try this out, I would highly suggest it. But there's a way for you to cannulate the cadaver such that you can create this real-time model that allows for intraoperative. You can do a simulation for a carotid blowout, and here's the example of that. And you can see this carotid laceration here, and then also simulation of CSF leak repairs. And I think that becomes very, very, a very, very useful tool. And they actually, they validated this, right? So they did this study where they looked at people's reaction time to a carotid blowout. So they were doing an endoscopic and a nasal approach, and then they simulate a carotid blowout. And then they have somebody try to repair that blowout before any sort of knowledge, right? And then what happens is that they'll watch a video of the senior author, which was Gabby, doing the repair, and he also goes through what the steps are in terms of getting a muscle, putting the muscle on, putting a cottonoid on top, and then switching those out such that the muscle is directly in contact with the area that's ruptured in the carotid. And there was a significant decrease in blood loss and in time to sort of get control of the bleeding between trial 1 and trial 2. That's when they had the sort of teaching and training, and then improved some variability between trial 2 and trial 3. But the most variability was sort of that guided knowledge, which he did in the lab with them. So I think this is just sort of a proof of concept of how, anatomic teaching, even though some people can claim, oh, well, it's not the same because it's not bleeding like it is in the OR. There are ways in which you can really get pretty close. And in terms of the anatomy, at least, for skull base and cerebrovascular pathology, you get very, very good understanding. It's not just the oh, do the blood vessels look like there's blood in it, but it's really understanding the relationship of where things are, right? Because one of the things about skull base is you're trying to get to somewhere without causing damage to all these other important structures. And the only way to avoid damage is if you know exactly where you are at all times and what you can hurt and how to avoid it. So in conclusion, I think time in the OR is necessary. Time in the lab is necessary. The 10,000 hour rule is sort of irreplaceable. You got to have that. In addition to that, aptitude and certain talent is important. And how do we cultivate people who have that talent, right? So perhaps it is okay that most people, reach the RRC competencies, but then there are certain people who are talented or have that aptitude that you should develop. And those are the people that should be going into the CAST accredited programs. Master surgeons are lifelong students of anatomy. So skull-based cadaver labs, simulations when able, and much of the learning curve has to do with intraoperative judgment as well, right? So you have to translate that into the OR. These are some pictures. We know we've done certainly in Arcane's lab, we've done spine labs, we've done peripheral nerve labs, we've done yearly anastomosis labs, we've done several skull-based labs a year. And I think, I really highly encourage the residents to come out, even if it's like 2 or 3 hours. There's actually data to show that even if you come for those 2 or 3 hours or 1 hour, it's actually beneficial to your learning. We have a few fellows this year who are helping out. They're there every day. So if anybody is interested in, learning something or just going in and doing a dissection, you should definitely come by and, they're there and they're there to help you. And with that, I invite you to join us next Friday for our next workshop, which will be on the orbit and orbital approaches.
Well, it's great. It's great talk, Carolina. I'm going to hopefully shift the focus from cadaver labs to the basic science lab. Put some time and effort there too as well. No, I'm just kidding. So I thought I'd give a talk today on neurosurgical strategies to conquer the blood-brain barrier, kind of a from a neuro-oncology point of view. Is like, what can we do as neurosurgeons to kind of improve the efficacy of our treatment and kind of looking at steps forward. And I don't have to show this curve, but everybody, I think I'm obligated to, that everybody sees this curve from New England Journal of Medicine from Stoop with overall survival of 16 months for GBM, and really this hasn't changed much in the last 20 years. Primarily the main reason for this is if you look here at the bottom circle here, these are the chemotherapy agents that are really approved on the by FDA, the oncologists are giving, and they really have a very poor brain uptake, and really there's like only a few that really have an ideal uptake into the brain. And so intratumoral penetration of these drugs is really, really poor. Temozolomide is one of these that have a somewhat favorable profile, but even then, if you ask chemists, its profile to penetrate the blood-brain barrier is really not that great, and its PK values are pretty low. Do any residents know some characteristics of drugs that go to the blood-brain barrier? What are you looking for? What are some small things that are helpful? Size. Okay, so low molecular weight. Yeah, it should be lipophilic. those are kind of, pretty main ones. You want to make sure it's low size, like lipophilic or hydrophobic. And then the other thing is, whether or not it has like binding to different receptors on the membrane. So, essentially, the blood-brain barrier is formed by this kind of neurovascular unit. You have your perivascular pericytes, astrocytes, and your endothelium. And so unless you have some disruption of that, whether it's surgery, some adjuvant treatment, or you directly go past the blood-brain barrier with any type of therapy, you're not going to really get any efficacious treatment. So, now I'm kind of just going to discuss really broadly about different strategies to overcome the blood-brain barrier. There's now not new talks at intranasal delivery, nanoparticles, focused ultrasound, convection enhanced delivery is kind of the thing we're most familiar with, and intra-arterial chemotherapy, which is kind of on the come up as well. So, we've looked at this in a lot of different systematic reviews. When I was a medical student as a resident, Gliadel wafers has been like kind of this implantable chemotherapy agent, which was had some improvement in progression-free survival. Brachytherapy, intra-arterial chemotherapy have all really been investigated as kind of a local chemotherapy rather than giving systemic drugs. You can kind of give these locally, implant them into the cavity, but really the complication rate for gliadel brachytherapy was really quite high, on the order of greater than 50% of patients had some sort of adverse event when you're implanting these therapies. Intra-arterial chemotherapy has been described for glioblastoma in a variety of different modalities. Christian wrote the seminal work on this when he was a medical student, and the efficacy wasn't really that great, mostly because it was a transient approach. So I'm going to kind of go over these kind of 5 kind of newer topics here. We in Miami, I think we have a unique focus in laser, and then I'll talk about convection enhanced delivery briefly. But laser interstitial pneumotherapy, we're all very familiar with it. There's 2 main companies, Monteris and Visualase. We use the Visualase system here, but a lot of other institutions use Monteris. And the idea is you're basically able to induce ablation into the tumor cavity and have a real-time thermal damage estimate. And so this is kind of, this is not new. This is being done in interventional radiology quite a bit. In neuro-oncology, we've been using this for the last 10 years. But really, the main question we ask ourselves is what's the biology behind laser? What's happening on the cellular level? And really, can we utilize these changes to improve our approach? So we know, and this is kind of that, when you get into the greater than 46 degrees Celsius in the middle of the actual lesion, you get higher amount of necrosis. When you go outside, there's kind of sublethal damage, and you actually get this physiological hyperthermia that actually opens up the blood-brain barrier transiently. And so this is kind of the area that we're most interested in, is these kind of 2 outer zones, is what's happening on these 2 outer zones that really kind of help out with our treatment. So whether or not be opening the blood-brain barrier, inducing heat shock protein release, or increasing antigen presentation. So these are kind of really important concepts that we're really looking to in the lab and seeing what's happening. And this is kind of the landmark paper that was published by Wash Hughes group, kind of demonstrating that the blood-brain barrier is disrupted at 1 to 2 weeks after laser. And you can see, the brain specific enolase levels are maintained to be high, all the way out, to 6 weeks, on this curve. So this is a really unique kind of thing you can do as a resident. You can look at patients who undergo laser ablation. You can actually take their serum brain specific enolase levels and look at them over time to see whether or not the amount of power you give or the amount of ablation you have, causes changes in these serum levels over time. And this is kind of and you can see if that correlates to overall outcome as well. So these are important things to look at, that we can easily do. And so Peter Fecchi's group kind of looked at this, and they said, okay, well, maybe in the outside of the necrotic zone, you actually have an increase in inflammatory cytokines, you have activated microglia, and you destroy these kind of this neurovascular unit. And so, this sounds great. Everybody's talking about it. Anybody sells you a laser in spine surgery, you're like, okay, does this really work or not? Same way, there's a lot of skeptics. There's especially the older group of neurosurgeons and neuro-oncologists are like, well, this is not, you guys, this may not really work. And I think that there's a lot of skepticism in this. And so, we published a lot to kind of try to increase, the increase more knowledge on the actual therapy. We've looked at our outcomes for newly diagnosed GBM. These are patients who otherwise would get biopsy alone, and our overall survival was 24 months in our group. And this is really an early investigation. So I think our outcomes are actually a little better if you look at them over longer time, but it really depends on patient selection. So we looked at predictors of which patients benefit, and the higher you ablate these patients, the more you ablate of the lesion, the better these patients end up doing. This is a patient with kind of a deep glioma, kind of right under the motor strip. The questions is, how do you approach this? If I asked Dr. Morcos, how do you approach this? It'd be very different from if I asked Dr. Komentar how you'd approach this. So, you have a lot of different opinions. This is a patient who had an IDH wild type GBM. We ended up doing laser ablation and biopsy. This was quite a big time ago. So 93% ablation. And if you look at this patient, this is immediately post-operatively, not much of a change. But over the next 3 months, she starts her adjuvant chemotherapy. 7 months, you can see the lesion is regressing. 12 months, the lesion has essentially gone away. This is 1 year, IDH wild type, newly diagnosed GBM. You continue to follow this patient who's now just maintained on standard treatment. 2 years later, just a wisp of enhancement on the corpus callosum. At 4 years later, really stable disease. So, I mean, this is an interesting kind of thought process. What is making this patient uniquely responsive to treatment in this setting? And, she actually got started on treatment within a week or two after laser ablation. And at 50 months, she just had a little bit of disease anterior to her cavity. So, this patient, 4.5 years with newly diagnosed IDH wild type, unmethylated GBM.
What'd you do with that recurrence?
Actually, she got laser again, actually, to that recurrence. She's doing well. I mean, the only thing I'd say is the neurocognitive effects from the radiation have affected her cognitive ability. So I think her functionality has decreased to the point where, I think she has a little bit dependent cognitively. But that's like kind of a long term over the course of the radiation effect. So she got adjuvant chemoradiation, yeah. And so really, if you look at outcomes for patients with unresectable GBM or patients who have deep glioblastomas, their outcomes are much worse. Some studies say 9 months overall survival. We've looked at butterfly gliomas, we've done meta-analyses on these as well. There's a lot of advantages. You get cytoreduction, you open blood-brain barrier, you have a low risk profile, low risk of wound issues, and they can start chemotherapy quite early. So you can start chemotherapy and radiation, within a 7 to 10 days after treatment, as long as you have your pathology and you have, it set up. So there's really a lot of benefits in this sense. I will stop kind of boring you with all these graphs, but essentially, Javier, like a long time ago, basically looked at, basically the neutrophil lymphocyte ratio, and patients who had a higher delta neutrophil lymphocyte ratio had improved outcomes. And so this is an interesting patient. This is kind of from the molecular level to look at this. This is a patient who had, and you look at this lesion, it's a frontal lobe lesion, got a patient with a biopsy, and you take a look at the kind of molecular milieu here. You see really low CD8 infiltration, low PDL1 levels, low macrophage infiltration. So this is kind of standard immunosuppressive glioblastoma environment, right? You take a biopsy of this thing, IDH wild type, 70-year-old patient. Most people would resect this tumor, and I think that's probably standard of care. It's a right frontal lobe lesion. You can get a nice resection. At that time, the patient underwent laser ablation. You can see the laser ablation cavity, and got adjuvant chemoradiation. You can see now the inflammatory response that's really incited by the chemo and radiation and laser after this biopsy and laser. So now you're looking at this patient, this worsening edema, question of tumor progression. This is kind of washed serially. It's getting progressively worse. Luckily, the patient underwent surgery, and I'm excited about it because now I have the tissue to look at and say, well, what's changing in this environment in this patient, right? And look at this. So you see IBA1 level, which is a activated macrophage M1 phenotype, has increased significantly, and you have CD8 infiltration, which is a good prognosticator for patients who have GBM. Now you look at this image, you're like, well, that's not a good prognosticator. So the patient underwent surgery for resection of this and was followed. No chemotherapy, radiation. And if you follow this patient 9 years after the initial treatment, he is running marathons, or he's biking, whatever, 30, 40 miles a week, at 75 years old, functionally completely independent. I called him, maybe like a couple months ago, and he picked up the phone. I said, what? And he's like, yeah. I was like, Norman? Oh, no, sorry, that's a HIPAA violation. I was like, you're still alive? And he said, yeah. He's like, I know I'm not supposed to be. He's like, but it's interesting. So, there are changes in the immune infiltration. And I think this is kind of an important thing to look at. So you can see pre-lit, the immunosuppressive environment, and how we've changed that after laser and interstitial thermal therapy. There's a lot of clinical trials going on in Miami. We're going to be starting this new trial called Starlight, kind of synergisting treatment with laser ablation and antiretroviral treatment, kind of meshing two of my loves. And, I think this is kind of going to be an interesting treatment. Now I'm going to switch focus to intratumoral injection and convection enhanced delivery. The idea is that when you inject using convection therapy, you're actually able to get more diffusion within the tumor versus non-convection approaches where they basically reflux up the catheter. This is actually a paper that Arya wrote looking at DIPG. This was done at the NIH, where they injected Pseudomonas toxin into DIPG patients. And you can see that if you use a convection enhanced approach, you actually get good penetration. But if you look here on the right, if you inject too quickly, you can actually have reflux of the chemotherapy agent all the way up the tract. So this is really important about using convection enhanced approaches in these patients to try to improve the delivery of your agent. And so this is a landmark paper that was published in August. Nobody really paid attention to this study, but this is a Japan study where they injected intratumoral oncolytic herpes virus into the tumor cavity of recurrent GBM. So these are recurrent GBM patients. They did a phase 2 trial, and they injected 6 times into the cavity. So you injected once. If they still have progression, they injected again, and they injected again. So you're talking about 6 separate surgeries, recurrent GBM, but the outcomes for this patient were 4 times improved compared to the standard of care. So now this is FDA approved in Japan as standard treatment for patients with recurrent GBM. So the first time you're talking about a viral therapy being approved for GBM. And the main difference here is they did convection enhanced delivery, and they did it repetitively. So they induced the immune response over and over and over again. So, I think the key here is that, our initial one-time approaches, this one-time surgery, is really changing. And I think that's what we need to do moving forward. And so a lot of benefits to convection enhanced delivery. I'll talk a little bit about intrathecal delivery. This is kind of controversial of delivering intrathecal agents to GBM. And the main reason why this is controversial is because really the penetration of the therapeutics within the CSF outside is pretty low. But in select patients who actually have leptomeningeal GBM, there is some benefit to giving intrathecal chemotherapy. There's a few papers on this, and one of our fellows is writing a review article on this right now. But the idea is that maybe you're targeting the stem cell niche. And so, these are really, really small journal articles. But the main issue with giving intrathecal chemotherapy is if you give it via lumbar route, you really don't get good penetration. You can see the kind of all the chemotherapy agent is basically being kind of localized at the bottom. So actually what you have to do when you give these thecal agents is actually put like a vibration vest on these, this is in monkeys, but that actually improves the penetration and actually goes way more rostrally. So MR guided focus ultrasound, this is kind of more exciting. I think the functional guys are more interested in this, but Graham Woodworth in Maryland is really kind of pioneering a lot of this work, essentially using MR guided focus ultrasound as not an ablative technique, but to kind of open up the blood-brain barrier and transiently open and give chemotherapy. There's a new trial basically using implantable local ultrasound. So that we're going to hopefully start this here as well, but basically doing a craniotomy, taking out the tumor and then implanting this mesh kind of implant. This is a company called SonoCloud. Essentially what you do is you basically now have this ultrasound device that's underneath the bone flap. You can basically access this, inject microbubbles at the same time as you give the ultrasound sonication, and you're basically able to locally open the blood-brain barrier up anytime you want. So this is kind of every 2 to 3 weeks, basically opening the blood-brain barrier transiently, giving in this case, they're giving, I think, cisplatin or I forgot exactly which chemotherapy, but a non-permeable blood-brain barrier, non-permeable chemotherapeutic agent, and now you're basically allowing it to get into the brain and looking at overall outcomes for difficult to treat patient population. So this is going to be a multi-center trial, hopefully being started here as well. And then targeted therapeutics. So this is kind of goes back to this whole idea of which therapies can actually get to the brain. And so, I think we should all really kind of pay attention to which drugs are going to actually go to the brain and have good blood-brain barrier penetration. We've looked at this from a kind of transcriptomic approach, as in, can we identify drugs that can reverse the gene signature of GBM, and two, can actually penetrate the blood-brain barrier with good efficacy. And we've found several candidate drugs that actually basically reverse the transcriptomic signature of glioblastoma and also can penetrate the blood-brain barrier at really low concentrations. And so this idea of identifying drugs that have a favorable pharmacokinetic profile is really, really important. And so, I really think the current paradigm must shift. We must stop thinking about, glioblastoma and these malignant brain tumors as, just, kind of resection only. I think, when you think about clinical trials for all of our patients and kind of how we can, improve the efficacy of our current approaches, we can't be living in like this two protocol, 2005 era anymore. And I really think that, as a leading academic center, we really have to think about reinventing the wheel, changing the paradigm, enrolling our patients in more clinical trials to kind of move the needle, because otherwise we're going to be, we're doing our patients a disservice. So with that being said, thank you. If there's any questions. I know. I feel bad. I ignore my daughter too much.
Radka, very nice.
Thanks.
Radka said they're starting a focus ultrasound trial for DIPG up there. Our pediatric folks are going into this.
Yeah, I think that the children's, I don't think anybody, well, Dr. McCray is here, but the children's, the focus ultrasound is ablative. So I don't know if they've actually purchased the research version, which is allowed to at the lower frequency to open the blood-brain barrier. I know Victor's been looking at this at Baptist because they have one that they're,
There are two versions.
yeah, there's two versions.
Similar to lit this issue, and then there's a different for opening the budget. So, the Toronto group at six kids is probably the farthest along in terms of opening the blood-brain barrier during the LPG with focus ultrasound. And then in terms of induction, delivery to kids, Mark Sedan, that track photo you showed of the CED reflux. That's a really important point. So when we biopsy the NTG, we usually go from the cerebellum, but specifically for the CED studies, they go above to have a longer track to help deal with the reflux. Hoping we'll have our insurance here for kids. Hoping very soon we'll switch it primarily to we did treat one thing with the passion fruit FDA.
Yeah, I forgot to mention that. So these are older slides, but yeah, that was Dr. McCray is starting her own super selective intraarterial chemotherapy for pediatric high-grade gliomas here soon. So a lot of excitement.
There was this slide that's always shown mortality of GBM over the last 50 years, and I heard it in the tumor section presented this flat line. Are we able to recently drop this line, or is there? You know what I'm saying?
Yeah,
any better overall?
I think to be honest with you, to be intellectually honest, the overall survival from Stoop curves, if you look at the Stoop treatment from then to now, our patients are doing better overall because the radiation, our radiation conformality is better. Our surgical techniques are better. And I think patients are getting treated earlier compared to, back then. So I think probably 2 years is probably now so whenever you look at these trials and they compare to historical controls and they look at their outcomes, you really have to keep that in mind. So I think if your outcomes are 2 years, you're probably somewhat at the standard of care. So you really have to I think we've done a little bit better job, but I don't think enough.
And have people looked at those great occasional long-term survivors and learned anything from them? I mean, I remember one of Hero's patients, like 20 years.
We have, Debbie and I have been following two patients. One is over 20 years. The other 20, how long have we been here, Jack? Because they did it the year I got here. The wife of a surgeon, Dr. Hartman. She's 27, 28 years old. And they had a common denominator, those two glioblastomas that reviews the pathology. We don't have molecular profiles, so we don't know what the molecular profile was, but they both have glia now.
Oh, wow. Yeah.
But remember, we used Leadell only when tumors were well localized and you thought you got a complete resection and you got a nice cavity. So a lot goes into not only the use of Leadell, but in which cases use Leadell.
And what's the name of that neurosurgeon who was fired because with no IRB or no consent?
Yeah.
You know, he put.
It is Irvine. He's putting yeah, it was
What did he put bacteria?
It-
I think it's like infection.
is E. coli or something, yeah. Yeah, he lost his research privileges for that. But there's
I'm
a,
curious, I mean, probably we don't know the results of that crazy stuff.
no, I know there's a whole interesting infections in cancer kind of in GBM, you know, a history of injecting like Clostridium into the brains of patients in the 1960s where they developed brain abscesses, you know, afterwards, and all of them died pretty quickly, but.
Okay. So I thought I'll talk about skull-based approaches to vascular lesions. Is kind of half of this talk. You know, you can identify surgeons who did vascular, surgeons who did skull-based, surgeons who did both. You have endonasal endoscopists some of whom do both, but most endovascular people don't do too much skull-based. So it's like following up on Carolina's talk, kind of whatever you like. I mean, you see, I'm sorry, my picture is there because it was a Zoom, but the intersection between vascular and skull-based is indeed there, but of course there is a whole microcosm of interactions between vascular, skull-based, and other things. How does vascular expertise help skull-based? You can think of many examples: ICA balloon test occlusion for tumors, pre-op tumor embolization, intraop repair or bypass of injured arteries and veins, microvascular skills, dissections, exactly what Carolina talked about. The other way around, skull-based helps CV, again, appreciation of anatomy, knowing when is an approach enough. You don't want to do things for their own sake, and you get familiarized with toolboxes of approaches. And yes, there are certain characteristics that are common to both. The skill that's based on anatomical knowledge, delicate microsurgery with intense consequences to the patient. I mean, you know, I don't need to tell you, a minor mistake in those disciplines and you end up with a disaster. Similar dissection techniques. You have, of course, ability to focus on long cases, stamina, and adaptability. So let's go over some examples of skull-based approaches used to approach vascular lesions. There are many, many examples, but I'll give you a smattering of examples. So of anything written in blue is the skull-based part, of course, and anything written in red is the vascular part. So a far lateral approach for a complex pica aneurysm. I'll show you what the aneurysm looks like. It's bilobed. It's at the origin of the pica on 3. You can see here it looks like it's easily clippable, but you're not seeing the other lobe of it. You will see it in a second. Right there, poking out. So at the time, certainly I did not feel endovascular was the way to go. So this is far lateral positioning, hockey stick. And here I have to cross the midline because I thought I might need a bypass. So this is a so-called teardrop craniotomy. This is the drilling of the paracondylar bone. Again, as Dr. Heros described many moons ago, you're not really drilling into the condyle, you're drilling just up to the condyle, but just enough to make this opening very flat. You see the dura is not tented in the middle. It means this is a good drilling. You've drilled far enough. And you see I cross the midline, spinal accessory nerve, vertebral artery entering. and look at this heavily atherosclerotic aneurysm, which of course I tried to clip but couldn't. I kept occluding the pica, but I crossed the midline. And this is a view I want to show you. You see that if we had not used the far lateral, how would we get this view? You can't. So unless you're familiar with skull-based technique, you cannot do the best possible approach for some complex vascular lesions. So I proceed to do a bypass we're not going to look at these things. I want to show you concepts, and side-to-side bypass and then trapping of the aneurysm. And that's a post-op angiogram. Patient did very well. Aneurysm is gone right there. And you can see the bypass, the side-to-side bypass. Okay. Transcavernous approach to clip a really complicated, multiply recanalized basilar tip aneurysm, which of course are becoming a surgical rarity. This patient had coiling elsewhere, recoiling, and then recanalized. At first, it looked pretty good. Recanalized quite quickly at 3 months, recoiling with an Enterprise stent going into the left P1 and recanalized again. And of course, now developing mass effect on the brainstem. So yeah, we can certainly perhaps push the envelope, and Bobby can tell us a little later, pipeline through it, or try to do a Y stent and coiling. But at the time, I felt this was rapidly growing and it's going to fail again. And often, as you know, these cases, once they start becoming thrombosed, partially thrombosed, it acts like a tumor. So I thought the best thing is to do the maximum exposure I can. What does that mean for a basilar tip? That means a transcavernous approach. Here is a third nerve. So again, here, of course, unless you know the anatomy of the cavernous sinus, you can't do that. So I've skeletonized the third nerve. I'm now skeletonizing the fourth nerve. We just missed it before. I'm drilling the posterior clinoid, and I barely have any proximal control right now. Until I drill the posterior clinoid, then I have proximal control of the basilar. And I have the right P1. This is combining the pretemporal approach, again, that Dr. Heros described many years ago, with a transcavernous. So it's pretemporal, transcavernous. And, I had to open the aneurysm and cut through the coils. And you could see, in spite of a huge exposure, I barely had enough room to work. So you can imagine it's totally not doable without that transcavernous addition. Going something simpler. Again, we don't do many of them anymore, but when you need to do them, it's really not very difficult. The small basilar tip artery aneurysm. So again, pretemporal half and half approach, which I consider a skull-based approach to do this easily located, kind of middle of the road height aneurysm. Again, just to remind the residents, who I'm sure most of you have not seen clipping of a basilar tip. I'm not saying it's wrong. I'm just saying this is how it's evolving. So you do a full Sylvian fissure splitting. You don't need extensive bony drilling. What does pretemporal mean? Exactly what you see here, the retractor on the temporal lobe, pushing it backwards. So you're in front of, not subtemporal. And that's a classic exposure. This is the opposite third nerve. I'm between the carotid and the right third nerve. And of course, the key is the perforators. So you use maximum or every window you can. Again, going back to Roten and describing the 4 corridors you can use, but Here I'm sizing my temporary clipping. Here are the perforators, and then the clipping should be the easiest move of your case. The hard part should be the dissection, the preparation of a 360-degree field as much as you can. Sometimes using a little cotton. I call it the third hand to push a perforator. You see, I'm clipping it just under that perforator. But that move that took 5 seconds, of course, is following several meticulous dissection moves that prepare the field for you. You cannot do that without a proper exposure. Okay, cranioorbital approach, another very useful approach. We all of us who do cranial surgery, of course, need to know, whether you're a skull-based surgeon or you're not. This is a recent case Bobby and I teamed up on very nicely, a very good example of a combination of endovascular and microsurgical. This is an 11-year-old. We spent a Saturday, Bobby and I, doing this case. Look at this monster, double aneurysm. We talked for several days. How do we do this? What's the difficulty here? Of course, neither of them is clippable. If Bobby were to put a stent in one, what does he do with the other? You cannot lose if you lose the carotid, how are you going to sacrifice the A1? What's going to happen to that ACA? Really complicated decision making. And what makes it even worse is, as you see here, let me see, I cannot, I have to freeze it to show you. Give me 1 second. I want to really show you. Yeah. What's that? We haven't sent the patient to genetics. No, yeah, he does. What's the syndrome? I forgot the name of the syndrome. Do you remember, Bobby? I don't remember the name. Yes, he has a syndrome. I can't remember. Nothing that we were familiar with that caused vascular things. Look at the outflow of ACA, one from here and one from here. So we cannot even do A3 to A3 bypass. So after a lot of discussions, we thought we'll do a cranial. And by the way, you can see the aneurysm is very high, the ICA aneurysm. So we did the cranioorbital approach, and why? Simply to get high enough to put a clip on the A1. So we wanted to do, so we did saphenous vein graft from neck to M2, and here is a clip on the A1. It wasn't easy to actually see the A1 in spite of the cranioorbital, and looking way up, just barely saw the A1 to put a clip. And after doing that bypass and reversing the flow, because we didn't want to occlude anterocoroidal artery, Bobby took the patient to the angio suite and did coiled occluded the second A1 aneurysm. And luckily the patient had good collaterals from the other side. So again, applying cranioorbital approaches to improve the exposure. Kawase approach, this is luckily a rather unusual indication. Kawase approach for macrovascular decompression of basilar artery for a recurrent hemifacial spasm. I had operated on this patient 2 years before. 56-year-old through an MVD due to a dolichoectatic calcified basilar. I couldn't really move it very much, and I just put some Teflon. The patient did get better for only 1.5 years, and it recurred. And tried Botox, didn't like it. He was sick, tired of getting Botox. Came back to me. I said, "Well, I struggled the first time. What am I going to do different this time?" The difficulty is the first time is the vector in which I needed to push the basilar. I couldn't do it through a regular retrosigmoid approach. So I thought, well, if I go from the front, then I couldn't push the basilar, but maybe I can pull it towards me away from the facial nerve. So what does that mean? That means I need an anterior angle of view, meaning a Kawase approach. And this is a nice editing of Eva. So this is a Kawase approach. I'm not going to go over the anatomical detail. So all I needed is just a direction from which to work. I didn't need to open the dura very wide. I essentially did what Kawase described in 85. If you go back to his original paper were on two high VB junction aneurysm, and he did this tiny dural opening and later realized, gee, if I had opened the dura over the temporal lobe and cut the tentorium, I would have a huge exposure, but I didn't need that. So you see, this is a basilar here is inferior petrosal sinus, and identifying the old Teflon felt I had put there. I'm stimulating to see where facial nerve is, and I needed to drill a little more over the IAC dura. And you will see in a second the basilar. It's white. It's so, I mean, that's why it's so atherosclerotic. Now, here is my old Teflon felt. So then this basilar needed to be pulled antero-latero-superiorly. That's a vector I needed. So I'm going to put a sling around it. But before getting there, I need to make sure I don't injure these tiny perforators. And I developing a plane right there. And once I have the space, here is what I usually do when I use a sling. This, as you know, this Gore-Tex stuff is nice, very slippery and smooth. I put it around it. And again, here is Eva showing nicely the schematics. And I put a screw in the Glasscock's triangle. Again, unless you go to the lab and work on this, I mean, it's very hard to understand this anatomy unless you actually drill it yourself. So you see what I'm doing here. So the screw is anchoring here. I'm pulling on the basilar. And when I think it's enough, I'll put a clip here holding it. So I know it's tough on the 2D image, but in 3D, think of what the vector I'm doing. I'm doing antero-latero-superiorly, exactly away from the facial nerve. And patient did very well. Luckily, could have had a problem. I could have given him a perforator infarct. I could have done a lot of damage here, but we certainly.
That's quite an operation for a cosmetic problem. Yeah.
The patient wanted it. Shall I start that conversation?
I'm very well.
It did go well, yeah. And he is hemifacial spasm free for 3 years or 3.5. And here is the skull base understanding of what's going on. And I think I probably have time for a quick last case. Kawase approach for a pontine cavernoma, same principle. So when you have this cavernoma that I watched, obviously you don't want to operate on them when they're like that, fully surrounded by brain tissue. Watch a familial cavernoma, by the way. It grew, she became symptomatic. Now, Kawase approach wouldn't be the only way to do this. I think today I probably would have done I probably would have done what I've done more recently, simple retrosigmoid with a splitting of the horizontal fissure of the cerebellum. It's really a nice, very simple approach. But in this case, this is a few years ago. I just did the Kawase, and I'm not going to show you the video. You know, it's the same as the last case. And but the key is this: you want an anterolateral view of the brain stem of the pons. And I thought that was the best angle in this case. I removed it. You can see the cavity. You can put your endoscope in there. This is fat graft. So you see the angle of trajectory, and we kept her hearing. We didn't injure semicircular canals. Here is a fat graft post-op. Gives you an idea of the angle of approach. And she did very well. Yeah, I'm gonna stop here. And just to remind us that some twins are meant to be separated, but I think skull base and open cerebrovascular are meant to live in harmony forever, like these famous Indian twins, Shivanvath and Shivram. There we go. Thank you very much.
So my funding and disclosures, most of our research supported by the NIH Department of Health, but we also work with pretty much all the major companies looking at new technology and developments, most of which goes back to support more of our research. And I think the interesting part about this is that the amount of time it takes to develop these devices. So many of the really interesting devices that folks probably haven't heard of, unfortunately, those are things that we can't discuss usually until they start hitting the first patients, because most of that ends up being confidential. So although we may play an early part in sort of assessing these things, it's not till much later that we see them in patients. And often that could be 2, 5, 10 years later. But anyways, when I think about my training in open vascular, endovascular, as well as skull base, that's certainly when my friends would say that I became, a complete tool. And I think part of that is, if you just have a hammer, everything looks like a nail, even if it's a rabbit. And, sometimes when you put those things together, you end up with a lot of nails in the head. So I think part of it is really, wanting to have all of the tools so that you feel comfortable with all the different approaches. Certainly part of that also is, when you go to your first job, you're not sure who you're going to have around you. And I'm lucky to have such excellent partners, which I think each of us have different foci and areas that can complement each other. I think we do see some pretty interesting things here in Miami that, potentially we might not see at other major institutions. So just a case to start off, 23-year-old medical student complains of severe headache while studying. It's the worst headache of her life. She collapses. She arrives comatose. She has hydrocephalus. She didn't improve with an EVD. She has multiple DWI alterations and watershed distributions on her MRI. She has ARDS. She has diabetes insipidus, and pretty much goes on to have every complication you can think of. Here's her CT scan. She has this fusiform pericallosal aneurysm that we went on to treat with microsurgical clipping, and she spends pretty much months here. But ultimately, despite multiple times almost removing care from her, she goes on to make, an amazing recovery. Just finished her master's, and this is her first publication on recruitment of patients for vascular trials. So how do we get, to that approach? I think aneurysms we see in all shapes and sizes, everything from really tiny. This is a less than 1 millimeter blister aneurysm that's pretty much the size of the smallest clip that we have, all the way through to our giant herniating aneurysms. And so I think this is pretty antiquated. When I was training, these were sort of the main two approaches. You either had clipping or coiling, which I think is, way far in the past. But still, we still have to go back, as Dr. Marco said, to some, pretty basic treatment options. This is a patient that presented with significant weakness, went on to receive sort of the maximal resection, this is a radial artery bypass, clipping. And, I think about if my brain looked like this after a surgery, I'd be pretty upset. Thankfully, this patient went on to make an excellent recovery. Patients like this, this 3 small aneurysms in close proximity to each other, this is something that we can treat endovascularly, but I think still surgery is a better option. But we've sort of moved away from the way that I was taught to do these surgeries, massive craniotomy, massive exposure and approach. And this craniotomy, maybe 2 inches, we can go down, clip all these aneurysms. Patient has a mini craniotomy, basically can go home the next day with a Band-Aid. This is, he signed a release for this, but this is the father of one of our neuro ICU nurses. Similarly, another patient that was coiled multiple times with this ACOM aneurysm, again, balancing the 2 different approaches. Certainly we have many endovascular ways to treat this. You know, this patient didn't want to keep coming back for angiograms, didn't want to be on aspirin and Plavix. So this is someone that we made a small incision just below the eyebrow. You can see here orbitozygomatic craniotomy, about 1 inch, filling that in at the end of the surgery with a little bit of cement so they don't have a cosmetic defect. But here you can see the coil mass. We can go down and put clips on this. So this is the postoperative angiogram. But certainly, you know, if you could get away with, you know, at least for me, with just poking me with a needle, I'd much rather have that than some of these other massive approaches. Still, you know, it needs to be balanced because it's not always the best option. You know, this is a patient that had these 3 aneurysms. This one was treated, I think, 6 or 7 times after initial rupture at an outside hospital, then ruptured again. You can see here with hemorrhage into the ventricle. And because they had basically, at that point, they tried to do an angiogram. Both of the femoral arteries were occluded, and then they transferred the patient to us. So we did a radial angiogram. This is a fetal PCOM coming out of the base. And you can see here a massive blowout of the coils. You know, I don't know that we have a reasonable or very good endovascular option for this. So this patient ended up getting sort of a massive surgery. But I think certainly as we go forward, we've got to be able to do better than these types of treatments. And I think we'd be really doing a disservice to our patients if we were still doing the same exact things in the next 20 years. This publication that we did, I think, was in 2014. Wow. So really, a lot of this stuff is already antiquated, and we've already moved on to so many new technologies. So how does research keep up with this emerging field? And that's certainly part of the reason I took the job here. You know, it seems like many years ago now, but we have biplane angiography, MRI, CT, ultrasound. That's really just for research side of things. So I'm going to skip this because we could spend, you know, an hour talking about all these crazy initial developments in endovascular aneurysm treatment, you know, where we used, or not we, but people used, you know, hog's hair injected in aneurysm, all sorts of really amazing things. As this moved through development of balloons, coils, you know, the first coils introduced in 1991, you know, we're already coming up on over 30 years of this technology. And then as we hit the 2000s, we really start seeing an explosion. Now, this takes us up to 2012. And if I put one line for every development since then, you know, we would just go through pages and pages and pages. So briefly, you know, we really have a short time to cover sort of a massive area. And I'm just going to breeze through just to give you a couple of the areas that are being worked on, which would be imaging, treatment, medical therapy. So imaging, we have a whole explosion of new areas that lead to potentially better treatment options for these patients, better patient selection. So 3D imaging is sort of a standard reconstruction of aneurysms, which we can do with MRI, CT, and the angio suite. And this is getting better and better now to include bony anatomy, as well as these other devices. So here you can see the stent, EVD clip, which allows us to see these things better and better. And so we need to be able to move towards less invasive ways to do this. 4D imaging can be coupled to angiography or CT or MRI to calculate alterations in flow. And so you can get indices of pulse pressure, shear force, and other things that might lead to improvements in treatment and also analyzing how well we're treating these things. MRI Nova is another non-invasive technique that allows you to actually quantify the amount of flow through a specific vessel, as well as direction. We have new protocols for CT, CTA, things like this stent protocol where maybe we don't need an angiogram. You can see here our old CTA. This is a newer CTA protocol with thin bony cuts. You know, on this, it looks like the stent has occluded the vessel. Here you can see the lumen is actually still patent. Microangiography is something that's being developed, and I think we're going to get there where in the future, really, we can start seeing down to almost a capillary or subcapillary level on an angiogram. Intravascular imaging. So this is something, you know, I can't believe, you know, we wrote a review on this, I think in 2000, I don't know, it's probably over 8 years ago now, but this is a very common imaging modality in cardiology. This is intravascular ultrasound. Evan Luther recently got a grant to couple this with some of our work in aneurysms along with optical coherence tomography. Both of these are intravascular videos, so it gives you an entirely different view. OCT is a image guided laser system within a microcatheter that actually takes a video from within inside the vessel. So we were testing this is over 10 years ago now, testing this in a phantom model. And you can see here, these are the tines of the stent that are poorly opposed, which you can't see on the angiogram. Intravascular imaging, also other modalities, is coming a long way. So this is actually looking with almost an endoscopic like view from inside the vessel, which I think is going to be a tremendous advantage. You know, maybe it's 5 years down the road, maybe it's 10 years down the road, maybe it'll only be 1 year down the road, but really understanding what is going on inside the vessel from an intravascular standpoint. Great talk by Ashish. We know that microscopic imaging with confocal microscopy, I mean, this has been around for tremendous amount of time, but even in my, you know, and since I've done my training where we're able to slice and stack, you know, maybe 2 to 3 stains, now we're able to get 6, 7 stains at a much smaller level. And I think in the future, this type of thing will be able to be coupled with non-invasive imaging. Molecular imaging, so tagging certain elements with a probe so that we can see active inflammation or changes, things like that. And the same thing that's coupled with that would be antibody mediated imaging. So again, you could design a specific antibody, allow that to attach to a specific cytokine or inflammatory element within aneurysm walls to see, you know, which aneurysms are quiescent and unlikely to grow and which ones have active inflammation and are progressing and more likely to rupture. Endovascular devices, I mean, we could spend hours talking about new endovascular devices, but briefly, you know, the major overviews are improvements in microcatheters that allows us to track and get to better locations more easily and more safely. Now, you know, we published more on dual microcatheter techniques as we've had improvements in microcatheters that allow us to treat wider based aneurysms without aspirin and Plavix or stents. Improved distal and guide catheters. And, you know, really almost every week or month, we're testing a new catheter or a new company has come forward with a better catheter that allows us to have more support to treat better aneurysms. Now, this was on the cover, that the catheter that Eric developed for transradial approaches and looking at radial versus femoral approaches and designing specific equipment for that has allowed us to treat aneurysms more easily and more safely. This was a large study where we collected about 2,500 flow diverting patients and found better outcomes with a radial approach. Liquid embolics, really not a big area for aneurysms at the moment. Onyx 400 was developed specifically because this can fill aneurysms better than coils, you know, whereas you're filling in all the cracks. And there's a number of companies that are working on new liquid embolic agents. These are some of the really old ones going all the way through to some of the newer ones, Phil, Squid. But a lot of companies are looking at different types of embolic agents that can fully fill an aneurysm. And I do think that there's a reasonable chance that we'll have some major developments in that area in the future. Coils, you know, I showed you the first coils were introduced almost 30 years ago. Now we have improvements in coils with larger diameter coils from multiple companies. This was another patient that we did a radial to PCA bypass, and then we sacrificed both vertebral arteries. Whereas normally this would be, you know, 30, 40 coils. This was, I think, 3 coils on this side and 2 coils on this side. And it took about 5 minutes to sacrifice the vertebral arteries versus in the past, you know, something that could take us hours. So lots of different companies moving on to deliver larger coils that can go through smaller microcatheters. And we've done studies, multi-center studies sponsored by various companies for a number of these different areas and still have a number of these studies ongoing. Different types of coils. So we often think of a complex coil that's made to create a basket, but now we also have these other types of coils that are better for finishing, or coils that lack shape that can fill in cracks and crevices potentially better. And so we have studies looking at those types of things. How about smaller coils? You know, this is a new coil that can go through an 013 microcatheter. So again, much smaller microcatheter that potentially can navigate through tinier vessels. So I think this is another avenue that's being developed. How about coatings for coils? So these were initial studies looking at bioactive coils. The idea was that once they hit blood, they could swell and take up more volume. And I think this is another area that's going to progress in the future, is potentially putting other coatings onto coils. This was a study published by Dr. Ho and his team looking at adding MCP1 to the coating of coils to increase fibrin deposition and lead to better aneurysm inclusion. What about coil-like materials and devices? So Medina was another one of these that's developed. It looks more like a flower petal. And when it sits inside the aneurysm, it's more likely to capture the next coils that are put within the aneurysm. So you can see here, it provides a better frame of the neck of the aneurysm, allowing you potentially to fill aneurysms in a better fashion. This is the Citadel study with Stryker. They have a similar one, and we'll be starting that study pretty shortly here. Canica, this is the Endostream device. This is another one. You can see here, it basically comes out like a wind that creates almost like a neck protectant like coil that can allow potentially for denser coils. So I think we're seeing a lot of explosions in coils as well as balloons. You know, when I was doing my training, we had one, maybe two balloons, and now we have tremendous number of different types of balloons, compliant balloons, but also super compliant balloons that better take the shape of multiple vessels. And that can allow for better balloon remodeling techniques. Stents. So tremendous advantages and advancements in stents, especially in the last couple years. Where in the past, this was something that we might treat with Y stent coiling. Y stent coiling is something that we I would say almost never do anymore, because we're able to get better and better outcomes with both balloons, but also combination of single stents. And we've looked at, our series, other series comparison of single stent coiling versus Y stent coiling. Obviously less metal, I think, generally speaking, is safer, but potentially if you fully reconstruct the base, you're going to get a better outcome. But I think now that we have better and better stent technology, this is becoming something that's even more of a thing of a past. So just a brief overview of the many different types of stents, where you have thin stents, intermediate, flow diversion, new covered stents, and many other platforms. So thin stents, initially, when I was in New Zealand, this was developed for aneurysms. It became our number one device, or one of the number one device for many years, to remove clots from the brain. But in New Zealand, we could actually detach the solitaire, and the benefit for aneurysms was very little metal coverage. So potentially patients wouldn't need Plavix for such a long time. We had the Enterprise stent, Neuroform stent. I'd say to some extent, some of these older stents have now gone through multiple generations, have become a lot easier, a lot safer over time as we move through improvements in being able to see the stents, but also how they conform to vessels. And the Atlas is sort of the newer version of this open cell Neuroform stent, which has really greatly changed how we're able to treat these aneurysms. As before, this might be something that would need a Y stent. You can see here, we're able to push the stent up and get much better coverage of the base. So I'd say pretty rare that we're using more than one stent. The Elvis is another one of these stents that has more metal coverage, some flow diverting properties. And I think you can see here some various cases. As we move through better balloons, we're now actually able to deliver stents through a balloon. So you can start out with a balloon type of coil approach. And if you have problems with the coils, or if you need to, you could consider deploying a stent within the balloon and removing it. What about devices to cover the neck, other types of stent-like technology? So this Pulse Rider is another one that we did a study on. It looked more like a flower that would cover the base of the aneurysm with less metal coverage. That's going through some refinements. The barrel stent, another one, again, that it can allow you to achieve sort of a wedged appearance. And so as we move forward, I think we're having better and better development of these devices. At the same time, we need to keep up with the studies for these things. The Eclipse, another scaffolding device here, you can see that looks a little bit like a wind that allows you to potentially cover really wide-based aneurysms for stent-assisted coiling. The Comanche, this is another one that we did some analysis on, and it's a device that was, again, developed for thrombectomies, but allows you to open and close a stent-like device for stent-assisted coiling of wide-based aneurysms. The benefit here is that when you're done, you can allow this to collapse and then remove it. So a lot of times you don't actually need to stent this, and unlike a balloon, it doesn't cause parent vessel occlusion. What about intrasaccular devices? I mean, I would say, you know, we really don't have time to cover all the major advances to here, but now, you know, it's not just web. We're seeing other devices getting to market. A lot of these have taken tremendous amount of years to develop and progress through, but we're going to have a lot of improvements in intrasaccular devices over time. One of them is the Ceres device. You can see here, it looks almost like a funnel. And this is just hitting clinical studies and at the moment, and I think we're going to need a lot more analysis of how these outcomes go over time. But this is a patient with this large fetal PCOM that was treated with a Ceres device. You can see here bridging so that there's flow diversion at the base, another Y-based basilar aneurysm. And I think we're going to need more follow-up and more research study to really see, you know, which are the optimal patients for these approaches. Flow diversion, you know, I think has now become a standard arsenal, you know, where we see images like this before, after, images like this before, after. And many of these cases have now become pretty standard, easy cases compared to when we first started using this. We would actually see reasonably high complication rates. We published a lot on this over time, coming up with better ways to do this. On top of that, we've had improvements in the generations of flow diverting stents, whereas we originally just had pipeline. Now we're on almost the fourth iteration of pipeline, and now we have multiple other companies that have developed flow diverting stents as well. So we saw over time, the more experience, like anything that you develop with flow diverting stents, we would see a drastic decrease in complication rates. On top of that, we're now finally seeing surface modifications for these stents to improve obliteration of aneurysms and decrease the need potentially for long-term Plavix and thromboembolic complications. So we did a lot of the testing for this. This is looking at this in various rabbit models. We did one of the first cases. This is dissecting basilar aneurysm that was ruptured, treated with the Vantage pipeline stent in a compassionate use situation. So sometimes these stents are really a major step forward for certain cases. This is a lot of the research that we were doing, partnering with companies, looking at how we can decrease thromboembolic complications with these devices. On top of that, you have multiple other companies now have come to the table with flow diverting stents. This is Stryker's Surpass device. I think originally we enrolled 4 patients in the original clinical trial, which was now more than 10 years ago. And now they've come out with their Evolve, which was their follow-up to this. And then more recently, they're working on coating their stent with this Carmida coating, which is a heparin coating that releases heparin over time with the idea that it's going to be less thromboembolic. This surface modification was actually developed in about 2001, I think, or even before that. So, you know, it really takes a long time to get these things to clinical market. But then on top of that, we're still going to need careful studies designed to assess how these stents potentially work better than what we have. Same thing with the Fred flow diverting stent. This was Microvention. They've now come up with their surface coating. And now we've seen an explosion of all these different types of flow diverting stents. This is the P64, P48, Acandis, and on and on and on. I feel like almost every month we're testing a new stent that's recently been developed. So these are many of the new stents that are, you know, going to be coming out in the pathway shortly. This is another one that we got compassionate use for that's recently developed. The Silk Vista Baby is a flow diverting stent that can go through one of our tiniest microcatheters. On top of that, we need larger stents. So this was another compassionate use case that we got compassionate use for a massive flow diverting stent that we used to treat this giant basilar aneurysm. And this was, I think we placed 6 millimeter by 50 flow diverting stents, which was at the time the largest one that we had. So sometimes, you know, small size or large size can be hindrances for us. What about covered stents? I'm not sure my videos will play, but you know, due to direct trauma, cancer, iatrogenic injuries, gunshots, often we'll see direct injuries to the blood vessels or something like this. This is a patient that presented with progressive difficulty swallowing. Here, you would think this is potentially a neck tumor. On the delayed follow-up CT following contrast, you can see contrast pooling in here. This is a giant cervical aneurysm that had been growing over time, causing swallowing difficulty. This probably took about 10 minutes to fix this. I basically put 2 covered stents in, which can be lined with different material that doesn't allow any blood flow through it. And so now even recently, we've seen even improvements in our covered stents. This is a new one that we've used. I think we're up to maybe our 10th case, and it's balloon expanded, and it's about 75% thinner than the ones that we had in the past. So it's allowed us to take curves through the petrous segments. Even now we've done cases up in the cavernous, even up into the ophthalmic segment when you potentially have a direct injury. The disadvantage of this stent, unlike a flow diverting stent, is if you have perforators in that area, it's going to immediately occlude those. So this is not a stent to be used, up near the choroidal artery or high up in the basilar. What about, all these benefits, in new devices? One of the challenges of these can lead to novel complications. And I think, this is where Dr. Marcos gave a nice talk on many of the problems that we're seeing on almost a daily basis now. This is a flow diverting stent that was being released by actually in neuroradiology that failed to deploy. This is another one, a giant PCA aneurysm that kept growing despite flow diverting stents. Another patient, this was received this flow diverting stent in an outside hospital, causing a dissection, throwing multiple emboli, and you can see here the aneurysm still filling. So we went on to treat this patient with a bypass and sacrifice. And so I think these new devices, although they're amazing and they can lead to less invasive options, they can also lead to new complications. And I think that's where really the research lab and clinical trials need to move forward. So just pushing on quickly, this is where I think a better understanding of the basic biology of aneurysms is incredibly important, because it can lead to improved patient selection and development of non-invasive therapies. And we've got to be doing things better than what we were doing in the past. So we're going to skip through this, but I think medical therapy is another major avenue that could be developed either as a pill or as a surface modification for coils or stents. These are some of the models that we use in the lab on a regular basis, making aneurysms in a large aneurysm model in various animals with similar sized vessels as humans. This is an aneurysm. This is a thrombotic ischemic stroke model where we can inject clots and remove those to test devices. And this is an AVM model where we can test new liquid embolic agents. So surface modification, I think stent modifications can lead to drug reservoirs, antibody mediated carriers, cellular carriers. So we'll skip through this, but these are many of the things that we're working on in the lab currently to lead to improved endothelialization, aneurysm obliteration with less thromboembolic outcomes. So I think in the future, all these things will need to be coupled together to well-designed clinical trials. And that could be things like new imaging, new medical therapies, but obviously also new surgical and endovascular therapies. So I think in conclusion, endovascular developments are expanding at a tremendous rate. Betal models are certainly indicated to test these elements. Novel imaging will be developed for diagnosis, risk assessment planning, as well as intraprocedural and follow-up assessment. Devices can improve our treatment abilities and outcomes, leading to less invasive approaches, but also lead to novel complications and require more inventive or better retreatment strategies to fix these problems. So these developments in technology can outpace clinical studies, and I think there will be a very strong continued need for well-designed trials to really inspect which of these devices are better than the things that we already have, and versus the common treatments that we usually use. So a little bit of a brief overview, trying to pack that into 20 minutes. Thanks so much. Appreciate it. Any questions?
Yeah, I think Mike has to get to some cases, so I think we'll leave his talk for another grand rounds. Is that what you prefer, Mike? Yeah.
That's better.
Okay. Thank you, everybody.